you very much once again for a very kind introduction. And then I'm very, very pleased to address to such wide, talented doctors from different continents, I would say, Far East and Southeast Asia and different parts. Thank you very much to Afreen and JB Chemicals for providing this opportunity. Now, today we are discussing this clinical spectrum of essential hypertension. What is new? And why we talk about new? Because it is very pertinent, especially in hypertension, because it has seen sea change over past century. Before First World War, during First World War and Second World War, earlier infectious diseases were the main culprit and cause of death. But during that time, there was a lot of attention was paid to infections, and they became nullified, nearly reduced. And then the cardiovascular diseases came. But alas, when we talk about cardiovascular diseases, at that time, people were concentrating only on coronary thrombosis and sudden death and myocardial infarction. But blood pressure was not given much importance because of a lot of wrong notions at that time. It was thought that blood pressure gets raised because body needs higher pressure to perfuse from top to toe, from brain, kidney to the toe. And then in fact, in BMJ 1935, there was a very funny editorials that saying that the only risk of detecting hypertension is some fool, some stupid doctor will diagnose it and he will try to reduce it, and all the organs, including kidney, brain, will start suffering. And no wonder, this is the most important man in the world, the President of United States of America, Franklin D. Roosevelt. When he died on 12th of April 1945, the news said in this extra bulletin that President dies suddenly at Warm Springs. But look at the right part of the in the right part of the slide. Was it suddenly? For several years he had high blood pressure, including more than 200 and 250 and 300, and yet he was not taking any treatment whatsoever, because, as I told you, because of the wrong notion at that time that hypertension, where it is called essential because it is essential to perfuse the body, and then we should not reduce it. In fact, if you see way back when the trials were done to see whether the blood pressure medicines help or not, you will be surprised to see that JAMA 1967, JAMA 1970, the VA cooperative study trial 1 and trial 2, you just see the number, the type of patients which were included who had diastolic blood pressure in VA1, diastolic blood pressure of 115 to 130, and half of them were treated with placebo, no treatment, and half of them were treated with medicine. Today, nobody will venture, even when the blood pressure is more than 90, nobody will venture to remain and then try to do a trial on placebo. But at that time, because we didn't know that, they didn't know whether the treatment helps or not. So we had in VA1 the diastolic pressure of 115 to 129, and VA2, VA cooperative study, diastolic from 90 to 115. And then no wonder that just with 2.7 patients, NNT of 2.7 means just 2.7 patients you treat with blood this medicine, and you can prevent the death. And then after that, various papers after papers started coming in the literature. And in 2002, there is a very important seminal paper by Levington et al. In Lancet 2002, which included meta-analysis of 61 prospective observational studies with 1 million adults, which included 12.7 million person years. And it was shown that merely 2 millimeter mercury reduction in systolic blood pressure will lead to 7% reduction in the risk of ischemic heart disease death, and 10% in the stroke heart death. So that led to the different definitions of blood pressure, what is normal and then how much we should reduce, etc. So the threshold at the definition of hypertension, and threshold at which we should start the treatment, and goal to achieve, till what level we should reach it. Now, normally we call normal range with the bell-shaped curve, and whatever that is more than one standard deviation, two standard deviation on either side is beyond the range. But that is not so. What we should see on the right-hand side, as you can see, if you see the event rate at a particular level, there is very minimal event rate. So that should be called as normal, rather than saying in the population what is normal. Because, for example, if you go to black population, then many of them who will have high blood pressure, so they will be having a different norm, which will the bell-shaped curve will be shifted to the right side. Now, for example, a pygmy, if will be called a dwarf in America, and then the dwarf in America will be called a tall person in pygmy group. So what we should see the effect of blood pressure, and we should try to reduce it. But it's not just the number of blood pressure that we have to reduce. There are so many things, as you can see in this slide, that salt sensitivity, obesity, the concomitant comorbidities like diabetes, metabolic syndrome, the lifestyle, sedentary lifestyle, then air pollution, the particulate material which is less than 2.5 micron concentration in the air, and so many things, urbanization, so many things come in into play. And then that's why, depending upon the population that you take, depending upon the drug that you take, different drugs will have different benefit. And that's why you will see the varied definitions and ranges to which we say that what should be called as hypertension, what is the definition of hypertension, the threshold at which we should start the BP treatment, and goal at which we should reduce. And then from time to time, once upon a time, you will remember that it was said that the goal should be age plus 100. So somebody who is 70 years, even 170 blood pressure is okay. But that is not so. I mean, these guidelines study the literature very pertinently, and then they start finding out what is the optimal limit to which we should reduce, to get the best benefit out of the medical treatment. And 2017 American College of Cardiology and American Heart Association, ACC-AHA guidelines made it very simple. Just make it 130/80 for each and every, whether it is general, whether it is old elderly person, whether it is diabetes, whether it is CKD, all this. Maybe Dr. Dedia will have little different slides, because to 2021 KDIGO said that in fact in renal proteinuric people that 120, not 130, but 120 is more desirable. So the different organizations go on changing, but we should say stick to 130/80, and in elderly people 140/90. Because if you don't treat blood pressure, as you can see, there is a continuum of damage, the vascular damage all throughout the body, in the kidney, in the brain, in the heart, and in the peripheral vessels, in the leg vessels. And then, as you can see in the continuum from hypertension, just as a risk factor, going to atherosclerosis, MI remodeling, ventricular dilatation, heart failure, end-stage heart disease, and similarly on the nephro front, which Dr. Dedia will subsequently cover. And the risk is modified as per the comorbidities. As you can see here, just merely having a hypertension, if somebody who has a blood pressure, you will see on the top column versus the lower column, who has hypertension with multiple risk factors or existing CKD stage 3, that is 30 to 60 EGFR, or symptomatic CKD stage 4, that is 15 to 30 EGFR, or diabetes and this thing, or target organ damage with risk factors. Then even the lowest range of blood pressure, that is 130 to 139, which we call it either high normal, or as current definition stage 1 also in American definition. So that also produces very high risk to all those consequences, what you can see in the left side of this slide, including stroke, heart disease, heart failure, CV death, so on and so forth. So what is new is, as on today, we should remember, especially in our Asian population, the Middle East as well as South Asia, the Southeast Asia, we should remember that there is increasingly younger population which is getting afflicted with hypertension. We have younger population with different targets at the end, every month end they have some targets to achieve, and then different financial goals to achieve, so on and so forth, which produces this. Then isolated systolic hypertension has become more important in treatment, because in very early time in JNC1, JNC2 only the diastolic blood pressure was given importance. Then subsequently the nighttime blood pressure, the night dipping, whether it is a dipper, a non-dipper, or reverse dipper, So the nocturnal blood pressure, morning blood pressure. So all those things have come up in the recent literature that which have become very important in managing it. So as you can see here, especially in this COVID time with this long work from home, people work even at midnight, and for the people who are working for American organizations and during daytime also they keep working. They're long, even after starting long commuting hours and so on and so forth. So all those things lead to unhealthy eating habits, sedentary lifestyle, stress, and that leads to this further aggravation of hypertension related damage. More importantly, the heart rate, especially in our Asian population, the hypertensive population have high adrenergic state, and they have increased heart rate, and which, as you can see here, and of course seen in different studies like Beautiful study and Shift study, heart rate is very important, and then which leads to myocardial oxygen consumption, increment in myocardial oxygen consumption, arrhythmiogenesis, and so on and so forth. Second part that I was talking about, the nighttime blood pressure. So nighttime blood pressure has got a lot of importance, which we'll see in the subsequent slide. And more importantly, the early morning surge, because it is at nighttime when person has parasympathetic dominance and low blood pressure, low heart rate. And certainly in the morning when the autonomic tone shifts from parasympathetic to sympathetic, suddenly the blood pressure surges, the heart rate surges, the platelet aggregability increases, and sudden shear force on the vessels, and then the atherosclerotic plaque increases. They can rupture and produce either stroke, myocardial infarction. That's why we get this high event rate, stroke or myocardial infarction with this morning surge. And as you can see here, this publication of way back in 2003, almost 20 years back, Cairo had shown, written in Circulation, that morning surge, sleep and awake, as it is increasing, it leads to this increased event rate in cardiovascular as well as cerebrovascular. And these are the three types of hypertension which in our clinical practice we come across quite often. White coat hypertension is the one in which patient has high blood pressure only in our clinic, but then he says at home his blood pressure is normal. When his wife or nurse or his daughter who is a doctor takes blood pressure which is normal, and only in the clinic blood pressure is high. That is because of anxiety and white coat hypertension. Sustained hypertension is the one who has permanently at home as well as clinic. But more importantly, what we are talking about is morning surge or nocturnal blood pressure that you can see in this bar diagram. So that has the worst target organ damage. And in this slide, we are seeing the left ventricular hypertrophy as seen on echocardiography, the LV mass index, gram per meter square, which was again adopted from Cairo in 2003 in hypertension. So this thing, Japanese Society of Hypertension presentation, this morning surge and nocturnal blood pressure becoming important. This is another paper by Cairo et al. In 2016, relatively recent, which came in JACC 2016, the HONEST study. And in HONEST study, again, it was a home BP, and then it was seen that with more than 21,000 people, hypertensive people. So you can see that as the blood pressure goes on increasing, the stroke rate and coronary event rate goes on increasing, and there is no Cruikshank J-shaped curve. As you go down and down, still there is no increment in, again, increase in the stroke rate or coronary event rate. So with this, we can be rest assured that as the SPRINT trial has shown, or this recent trials have shown, the STEP trial in China has shown, we can go down to 130/80 as shown in STEP trial in China, or as shown in SPRINT trial in multinational study. So this is, in short, the 24-hour blood pressure tracing, in which you can see how many readings, what percentage of readings are above the target, and overall BP load which patient is suffering during daytime, nighttime, the 24-hour period. And for this 24-hour and nocturnal BP, there are different ranges. Normally, we said that 140/90 or 130/80 for our office BP in those two definitions which we saw. But for nocturnal blood pressure, 120/70 is the limit. Whenever it is more than that, it is high, and more than 125/75 has significantly increased risk. And every 10 millimeter increase in the nocturnal systolic blood pressure, that produces increased death to all-cause mortality, total deaths, and CV morbidity. and that is in hypertensive population and even in general population. Even the person may not be hypertensive, it's only the 24-hour BP has been a little different in those different subgroups. You can see that with 10 millimeter rise we can get this 19%, 15%, 16% and 14% increase in death rate. In fact, this Journal of American Society of Nephrology has even again emphasized that CV this thing event rate with nocturnal normotension, nocturnal diastolic, nocturnal systolic, and nocturnal systolic diastolic. So with systolic diastolic hypertension with 974 people in this group, there is more than double the event rate of CV outcome, as you can see here in this particular C-STRIDE study, which is again a very large Chinese study with large number of people. So this is what we are currently talking about, the 24-hour BP monitoring, and this is especially just zooming the nocturnal BP, which normally dips down, and that is called as a dipper. There may be extreme dipper, non-dipper, and reverse, that is riser. And as you can see here, that this is associated with increased target organ damage, total mortality, CV event rate, so on and so forth. And this is especially more pertinent in diabetic population. As you can see here, that masked hypertension is more frequent, and this nocturnal is also more frequent in diabetic people. So in fact, in these people, more than our clinic BP, we should go for 24-hour BP monitoring. And this is very clearly shown in this particular slide, that clinic blood pressure or office blood pressure which we take in our clinic, that does predict that as you go from 110 to 130 to 150, there is an increase in the event rate. As you can see, a 5-year event rate in cardiovascular death, etc. But even more predictivity is for total 24-hour daytime, which one can check at with home BP monitoring, daytime BP, 24-hour BP, and the nocturnal BP, which is possible only with ambulatory 24-hour BP monitoring, but which is not so easy, and not so many people would go for it because of the cost involved, inconvenience. 24-hour, one is tied down to that machine even while working, going for work, etc. So what is the alternative? And that is home BP with this person, the person taking at home. We have to warn the people. We can give this picture to the every patient, that do's and don'ts, and then he should not be talking, he should not have taken coffee, his legs should be resting on floor, back should be resting on the back of the chair, arm should be resting on the table at the level of the heart, etc. So these are all the precautions which are given in American ACCHA bulletins, which we can keep in our clinic, so that patient can go through that when they are taking blood pressure. And as you can see here, the home BP has more pertinent value when you see the office BP versus home BP versus 24-hour BP in terms of easy access and then easy reliability, etc. But at the same time, we should remember that we should warn the patient not only about those do's and don'ts when taking the blood pressure, but then you should select the device which has got proper credibility, which is calibrated, and then intermittently the patient should calibrate it in our office clear BP. With when we take the blood pressure, simultaneously they should bring their device and then should see that it is showing appropriate. Because sometimes if it is inappropriately taken, and then patient may suddenly, without any doctor's advice, may change the treatment. Many patients say that today my blood pressure was 120, so I did not take the tablet, or today it was 160, so I took twice the dose. So that should not happen. So that is what we should want.